Hello, everyone. Thanks for joining today. My name is Stephanie. I am an M4, fourth-year medical student at the University of Iowa, and I'll go ahead and share my screen. There we go here. Slideshow from beginning. So today's topic is going to be psychiatry. And I think if you're new, let me know if you don't have the link for the soap note, but usually what we do is just walk through a case. You can take notes as you please throughout and fill out the soap note, and also just take notes if you want, because there's a quiz at the end. And it's supposed to be interactive, so a little bit of teaching from me, but also just interactive, getting ideas from you guys. And yeah, so feel free to ask questions and participate by either unmuting yourself, or you can put something in the chat. All right, so let me know if you don't have this. I don't have a link for the soap note. Okay, yeah, is anybody willing to put the link in the chat for Luke? Let me know, because otherwise I'll unshare and do that. But if somebody is willing to just copy paste the note that they have open right now, that would be great. Thanks so much. Awesome. Thank you, Chase. Okay, good. All righty. Oops. Okay. All right. So I just wanted to say first that today's case presentation, it's going to include some topics such as suicide, mental health issues. So if at any point you feel uncomfortable or you need to leave, that is totally fine. You can return whenever. You could still do the quiz if you want. I just want to make sure that you know that that is totally reasonable, because we want this to be a learning experience, but at the same time, I also want to respect everybody's needs. Okay, and then let me think of how to get rid of that little heart. I never know. I'm not good at the Zoom stuff. I say that every time, and then I never learn how to get rid of it. Whatever, it can just stay there. Okay, so we'll start with the case. So this is Ryan. He is a 12-year-old male that's presenting to your primary care clinic for an evaluation of poor sleep over the past month. So what are some causes of poor sleep in adolescence, and what more do you want to know? Stress, right? Yeah, exactly. Stress, maybe being sick, having an infection. Great. What else? Ask if he feels safe at home. Yeah, I think that that's a great one. Sleeping disorder. Yeah, sleeping disorders for sure. Okay. Awesome. Anything else you can think of? Yeah, prescriptions. Maybe he's taking some medications that can, make you sleepy, or make you have insomnia or lack of sleep too. Maybe he's taking a lot of caffeine or something like that. So great. So those are some causes, and then I'm guessing then too, so you guys want to ask him maybe some of these things, right? Ask him, are you on any medications? Do you feel safe at home? What's your stress level like? Have you been sick? What other questions? Anything else you'd want to ask him? We can also just go to the next slide and get a little bit more information. But he's having poor sleep. So is there anything specifically you want to know about his sleep habits? Oh, drug use. That's not far-fetched. I think that's a great one to add, especially, an adolescent, he's a preteen. Definitely not too early. Sometimes, peer pressure and they can be exposed to, alcohol, illicit drug use. And so that's definitely important to ask about. Yeah, how much sleep is he getting? What's the schedule like? Exactly. When does he go to sleep? When does he wake up? Is it at the same time every night? Great, awesome. So getting a little bit more information about the characteristics of what this poor sleep is. Okay. Okay, so questions to consider. We've already talked about this a little bit. So lifestyle factors. We had talked about like how often or what time does he go to sleep at night? When does he wake up? Does he have any screen time before bed? I'm definitely guilty of that, looking at my phone before bed, and then it takes me a little while longer to fall asleep. You don't get as good quality of sleep, research shows. Is he having food or drink before bed? If you're drinking before bed, maybe needing to get up to use the restroom during the middle of the night, that can interrupt sleep. Is he waking up in the middle of the night and looking at his phone when he wakes up? And exercise habits. Okay. And then description of sleep. You guys also pointed this out too. So too much sleep or too little sleep. So what does poor sleep mean? Does he wake up well rested? When does he go to bed? When does he awaken? Does he dream? Can he remember his dreams? Are his dreams vivid? And then any associated symptoms. Somebody mentioned sometimes illness can interfere with sleep. It can make you sleep more. Sometimes it can make you sleep less. So asking a broad review of systems for him. Is he having any other symptoms? Okay. So you have asked all these questions, and Ryan shares that he averages around 6 hours of sleep per night. He usually goes to bed around 10, but it takes him a really long time to fall asleep. He wakes up around 6:30 a.m. to get ready for school. He is in the 7th grade, and he's usually involved in sports, but he says he decided not to do basketball this year. He hasn't been exercising much. His mom says at a recent parent-teacher conference, Ryan's teachers have commented that he seems sleepy in class and that his grades have declined. He's typically an honor roll student, but now he's getting C's. His mom also shares that Ryan refuses to eat with his family, preferring to take his plate to his room and eat alone. So we got a lot of more information there, right? You guys have a moment to maybe write some things down. We can go back to the slide if we need to. But it looks like some things have changed for him recently, right? He's not doing basketball. He's a little bit more sleepy, in class maybe even. His grades have declined. Maybe isolating a little bit, not eating with his family. So let's ask about some past medical history first, before we move on to the next portion. So I guess he's just had a tonsillectomy. So he's had his tonsils removed when he was younger, but he doesn't have any other medical conditions and no allergies. For his family history, his mom has a history of hypertension. His father has elevated cholesterol. His younger sister named Emma, who's age 11, has no medical conditions. So thinking back to the slide and what new information we have about Ryan, is there something wrong with him, or do we think this is normal teen behavior? Oops. What do you guys think? Let me go back to the slide so we can read it. What do you guys think? Normal behavior? Concerning behavior? Seems like something is wrong. Yeah, exactly. Concerning since the teachers picked up on it. Yep. Yep. Exactly. So yeah, asking like, thinking, I think baseline is really important to take into account, right? Seems like things have changed for him, right? He's usually pretty involved, usually gets good grades. So something is probably going on, especially because, it's interfering with his sleep too. And his teachers have noticed, and now, it's serious enough that mom wants to bring him into the physician, physician. Okay. So if there is something wrong, which you guys seem to think that there is something wrong, that's great. Picked up on that. What would be on your differential? Remember, a differential is like a broad list of causes or diagnoses that could be causing his symptoms. Keeping it really broad. Yeah, depression. Depression is one, absolutely. Right. With teenagers, especially in adolescence, it looks a lot different. Depression can look different than it does in adults, for sure. What else? I know somebody had mentioned asking about drug use, and we don't really know about that yet, but does drug use maybe fit some of this? It could, right? So that could be on the drug abuse. Yeah, that could be on the differential. Great. What other things? Yeah, just general stress, right? So maybe he doesn't really necessarily meet the criteria for a psychiatric condition. It could just be that he's under a lot of stress, right? We don't know how long this has been going on, really. Well, I guess it did say with over the past month, but still, yeah, it could just be a lot of stress. Okay. I think those are some good ones. Any medical conditions you can think of that could be presenting like this? Somebody had said sleep disorders. I think that would be a great thing to have on our differential, right? He could be having an intrinsic, problem with sleep in general. And then that could be because he's not getting as much sleep, then that could lead to all of these problems. Yeah, insomnia, great. So different causes of sleep disorders. Adjustment disorders, someone said. Right, exactly. So adjustment disorder falls under our psychiatric disorders, and it depends on, whether or not we give someone a diagnosis of like anxiety or depression. It depends on like the length of period of time. Adjustment disorder is like usually less than 3 months, I believe. I'm speaking out of the top of my head, but it requires like a different timeline, but it really presents similarly to the issues that he's having going on. Great. I think we have a pretty good differential there. All right. So what else do you want to know, and how are you going to ask these questions? I know that's kind of, I guess, what I'm thinking, but are there some other things we haven't asked yet or things that we could ask that might clue us into one over the other? Yeah. Has he ever felt like this before? Great. Does he admit this? Okay, yeah. Does he have suicidal ideation? That's really, really important, right? Always important to ask. It's always important to screen people for suicidal ideations if they have some of these mental health issues, right? If they're coming in and they feel sad and depressed. Has he ever seen a psychiatrist? Yeah, great. Yeah, life stressors. What has been going on in life, right? Did he have a relationship that just ended, with somebody of the opposite sex or whoever he's interested in romantically? Are his friends fighting with him? Has he had a loss in the family? Great. Change in diet? Yeah. Awesome. So like all of those lifestyle factors that could be causing his issues, asking about them for sure. Okay. Great. Oops. And then, so what aspects of the physical exam might be most important in this patient? Neuro and psych. Yeah. Awesome. Yep. Great. Looking at his affect, mood, thought process. Awesome. As well as neuro, because, I guess we didn't even really bring up the neurological issues that would be on the differential. So things like, epilepsy, is something wrong with his brain? Did he have some sort of traumatic injury? Did he get a concussion we don't know about and he's having some issues? So good. Yeah, those are some important things we want to pay attention to on the exam. Okay. So something I wanted to note is that youth or adolescents, they might be reluctant to provide certain information when a family member is present. So oftentimes in well child visits, or if somebody's coming in just for a new problem, the physician will often ask the parent, if they could leave the room for a few moments and then ask some more personal questions, just to have the adolescent feel more comfortable and to build rapport. Also, a job of a pediatrician as your adolescent is moving towards adulthood is to slowly, have them take more ownership over their health. And so that's really important as well. But so you asked Brian's mother politely if she'd be willing to step out of the room for a few moments, and that while you perform a physical exam and you ask him some questions, and she says yes. So when Ryan's mother leaves the room, you inquire more into stresses at school or just stresses in general, and how he would describe his mood. So all the questions that you guys had been thinking of. So Ryan shares that the things at school have been pretty much the same. He has a close group of friends who are kind to him and very supportive, but recently he doesn't really feel like hanging out with them anymore. At the beginning of the semester, he had a crush on a girl he thought he might ask to the homecoming dance, but he lost interest and might not even want to go to the dance anymore. Ryan states he hasn't been feeling like himself. All I want to do really is watch TV and sleep. I just feel so tired and down all the time these days. I don't think I'm going to get out of this mindset. He denies alcohol or illicit drug use. Oops. All right, so here's physical exam. I'll let you guys take a moment to look at this a little bit. So what do we think about the physical portion of the exam? Yeah, flat affect, right? Slower speech. So yeah, keying in onto this mental status exam. Sorry, I'd gotten an email. Looking more into this mental status exam, it looks like the physical things are pretty generally normal, right? Nothing really sticking out that's abnormal here. But on the mental status exam, as Chase had mentioned, flat affect. So I put a little picture of a little smiley face that has a flat affect here, or the normal thing that would be a smiley face, but he's got a flat affect. So kind of expressionless, right? Not really showing emotions is what that means. It looks like he's got a little bit of slower speech too. It's important to think about paying attention to people's speech and how, soft it is or how loud it is. Sometimes pressured, fast speech can be indicative of individuals who are in a manic episode. If you've heard about that with people with bipolar disorder. So all of these are really important things to pay attention to when you are doing your physical exam with the patient. It looks like, importantly, no visual or auditory hallucinations for him. So he's not seeing or hearing things that shouldn't be there. Okay, so let's just wondering, what does linear thought process mean? Great. Yeah. Thanks for the question. I could have gone through some of those a little bit more. I apologize for that. So yeah, linear thought process is just, you're not going on tangents, right? So you have a clear goal in mind of what you want to say, and everything you say kind of relates to that. Whereas like sometimes, a tangential thought process would be, yesterday I went to Walmart and, I saw this stuffed teddy bear in the aisle. Oh, teddy bears. There was Halloween yesterday. Somebody was a teddy bear, and I got this candy, and it was, it was Reese's, and oh, Reese's. One time I went to the movie and ate Reese's, sometimes things like that, where they're kind of connected, but not really. And there's no like clear goal of like what you're saying. It's not linear. That's what that would be. Similar to kind of how children sometimes speak. But yeah, great question. What else? Yeah, of course. It looks like so insight and judgment are important ones. Insight is like, what is the insight into their illness? Oftentimes, so people might have poor insight into how severe maybe their condition is. So for example, individuals with anorexia nervosa that are receiving treatment where it's very severe, they often have poor insight into how serious their condition is. And it looks like in him, he has normal insight or appropriate insight, because he recognizes that, he's feeling down, he's feeling sad, and he's normal. Okay. So someone can provide a summary statement if you guys want, or you can just go ahead and put in the chat, like, what do you guys think is highest on your differential diagnosis? Depressed mood, adjustment disorder. Yeah. What are some of the things that make you think about depressed mood in this guy? What are some of our factors to factor into that he's evidence that he's shared with us? Yeah, loss of interest. What else? Feeling tired, not wanting to do anything. Great. So, he's aware of his own behavioral change. Yeah, exactly. He has good insight into it, and it's evidence that something has changed for him, right? Okay. Let's go into this slide, because I think it's important to cover, what depression is versus what just being a teen or just being a kid is. So obviously, if you guys have, are past your teenage years, I don't know, maybe we have some really young people here, but being a preteen and a teenager can be challenging, right? There's lots of changes going on at that time. There's hormonal changes, you're exploring different aspects of sexuality, maybe puberty, peer pressure, fitting in, can be overwhelming. And so normal adverse events and experiences can look like depression. And those are like life situations such as like losing a loved one, relationship issues, breaking up with a girlfriend or boyfriend, bullying, parents getting divorced, all of those things. So what differentiates depression, in addition to the duration and the severity of the symptoms, is the impact on the function, okay? So all of us have struggled with different things in our lives, right? We all go through grief and we all go through stressful periods, but if it significantly impacts us in a way that we're not able to function and do what we want to do, then that's more concerning, right? And so in Ryan's case, it seems like, his grades have started declining, right? That's a big one that kind of shouts that maybe this is, impacting his function. So depression in adolescence can impair functioning and derail, sorry, it's supposed to say derail, not derail normal psychosocial development. It often recurs and persists into adulthood, especially without early intervention. So individuals who are diagnosed with depression in adolescence are more commonly have depressive episodes throughout adulthood as well. So it's important to have early intervention. So adolescents with depression are at higher risk as well for other substance abuse and other psychiatric comorbidities. So important to ask about all of those things that you guys were talking about. So let's look here at the DSM-5 criteria. So the DSM is a diagnostic and statistical manual for mental disorders, and we use it in psychiatry to diagnose certain conditions, okay? And it usually comes with a set list of criteria, and if a patient meets a certain amount of criteria, then they can get that diagnosis. And it's helpful because it can point us to what medications might be the most helpful, things like that. So for adults, excuse me, to be diagnosed with major depressive episode, your symptoms need to last at least 2 weeks. They need to occur nearly every day. And then at least one symptom is either depressed mood or anhedonia. And anhedonia is like loss of interest in those things that you used to have interest in. So at least one symptom has to be either of those, and then you need 4 or more plus that, okay? Over a 2-week period occurring nearly every day. So these are some of the other ones you can have. So of course, depressed mood, sleep changes, loss of interest in things, guilt, decreased concentration, appetite loss or appetite gain, just a change in appetite, psychomotor retardation. So things like, the slowing of the speech, just moving a lot slowly, things like that. And then suicide and death. So this is and then it has to meet the criteria too, it has to obviously cause you significant distress and impairment in function. That's a big one, right? So we've all had these issues before, sleep changes, guilt, all of that kind of stuff when we go through difficult times in our lives. But what differentiates depression in a psychiatric condition from just normal life adjustment things is significant distress and impairment. And then obviously it can't be due to a substance or general med condition, okay? Because sometimes different medical conditions, which we'll talk about, can present as depression. So this is how you would diagnose adults, but teens and children look a little bit different, right? So many times you have to rely on behavioral signs from caregivers, teachers, coaches, whatever, because, teens will not often, come in and just say like, my mood is low. So, in Brian's case, his teachers have said something, his parents, are concerned. So here's how they present. In pediatrics, instead of like the depressed mood or anhedonia, which they certainly can have, they can also have an irritable mood. So sometimes patients in the pediatric population that have depression don't really present with depression or depressed mood. It can be irritable, right? So it's a change in the way that they interact with like their friends. Maybe it's like their mom saying that they just are having more outbursts at home. They're hard to get along with. They're fighting with their siblings. So pay attention to that, because that can be a sign that actually like depression might be going on. And then we've talked about lack of interest, no play after school, tiredness for energy, appetite, so maybe weight loss or weight gain, suicide and death, so self-deprecation, thoughts of disaster, abandonment, and hopelessness. And then they can have somatic symptoms. So somatic symptoms are just actual like body symptoms that are associated with it. So like headache, stomach ache, that sort of thing. And then how they present with like an impairment, their impairment is often at school. So it's like failing grades, or maybe it's like they're usually a really involved, athlete or something, and now they're just like not performing well. So things like that. Okay, so let's go through this then. And so give me some of Ryan's symptoms that fit, any of these criteria. So what about the depressed mood? Did he say he was depressed? Yeah, he said he was depressed. Great. What about sleep changes? Yep, exactly. Sleep changes. What about interest? Yep. Energy, it's lack of, low energy. He's got some hopelessness. He says, I don't think I'm going to get out of this mindset. And his significant distress and impairment is declining grades, as you guys had pointed out before. And he's also, somebody had mentioned that, he's aware that this is different than his normal. So this probably is really impairing his function. Okay, so, and then we'll do that. So, we need to still ask about suicide, and then we also need to do a workup to rule out other medical conditions. That's important as well. Okay, so a formal assessment for major depressive disorder. There are many different standardized tools. The one most commonly used in the adult clinic is the PHQ-9, or the Patient Health Questionnaire 9. In teens, you can use a modified version, which is present on this slide and the next. There are other assessments that, like the Child Depression Inventory and the Reynolds Adolescent Depression Scale. But the modified PHQ-9, I think, is one of the ones most often used, as well as the Child Depression Inventory. So you can see here how the instructions are for the patient to put in X if they have been feeling some of these for the past 2 weeks and how often. So for example, feeling down and depressed, are you feeling that not at all, several days, more than half the days, or nearly every day during the past 2 weeks? And then you go through all of these questions. So you guys can read some of these just to familiarize yourself with it. Like we said, eating issues, low energy, feeling bad about yourself, sleep problems, concentration, moving or speaking slowly, that's the psychomotor part, or being really fidgety or restless, thoughts of being better off dead or hurting yourself in some way. So they check all of those, and then what you do is you add them up. And so there's like a score that tells you if they're, at risk of depression, or if they have depression. So 0 to 4 is no or minimal, 5 to 9 mild, 10 to 14 moderate, 15 to 19 moderately severe, and 20 to 27 severe. And this PHQ-9, it's helpful for somebody that's coming in and, you're concerned about maybe that they have depression, but it's even helpful to just do on general annual wellness visits with patients, because you should always screen for depression, right? And so this can be a helpful way to screen someone for depression, even if that's not, the problem that they're coming in with. If it's just a general exam and they say they feel great, like, it's still really important that you screen people for depression. Okay, so we did that. And then, so it's important to consider the differential diagnosis, as we've talked about, because you need to make sure that you do a thorough workup. So can you guys think of anything that would be on the differential list for depression as it relates to comorbid psychiatric conditions? We'll do that first, and then medical conditions. So any other psych conditions that might, PTSD, great. So post-traumatic stress disorder. Okay, great. Somebody's had like a, really traumatic event happen to them, and now they're having, flashbacks, low mood, panic attacks, even anxiety. Yeah, anxiety can present as depression too. You can be so worried and so stressed about things, and that can impair your mood, and it can look like depression. What else? Anything else? You guys have mentioned substance abuse and substance use. I think that's always great to put on, because that can certainly present as depression. Okay, bipolar. Yep, bipolar is a big one, because bipolar disorder, while that is not the main topic of today's or tonight's session, it's very similar to depression, right? The difference is that they alternate between like depressive episodes and then like high mania episodes of mania, or like high mood feelings of grandiose and all of these ideas of going out and not needing a lot of sleep. So they kind of alternate between that, whereas depression is more just staying in that depressed state. Okay, so some of them that listed were ADHD, substance abuse, bipolar disorder, eating disorders, and anxiety. What about any medical conditions? You guys had already mentioned some of these, but you'd mentioned sleep before. I think that's great. Some sleep conditions, some neuro conditions. What else? Can you think of any endocrine organs that might present, if there was an issue with them, that might present as depression? Hypothyroid, yeah, the thyroid, any hypothyroid specifically, but yeah, any alterations in your thyroid hormones can mess things up, get a little out of whack. Good. Eating disorder, great, yeah. So that would still fall under psych as well, but yeah, it also has medical complications too. Great. Yep, epilepsy. Great. Okay. Yeah, you guys have thought of some really good ones. So obviously this list is not exhaustive, but thyroid disorders, especially hypo, sleep, anemia, vitamin deficiencies, menstrual cycles is a big one too for women, or anyone that has a uterus. So that's important because there's something called premenstrual dysphoric disorder, and that's when you start to have these depression symptoms like prior to your period, almost like PMSing, but just really bad PMS. And these patients are often treated the same as those that have major depressive disorders. SSRIs can help. Addison's disease, so like primary adrenal insufficiency. If you guys don't know, the adrenal gland has like 3 different layers. It's got one that makes cortisol, one that makes mineralocorticoids, and one that makes like androgens. And having adrenal insufficiency is like when you have an autoimmune, it's often caused by an autoimmune condition that just attacks your adrenal gland, and then you can have lots of symptoms, but depression and low mood can be one of it. It can be one of the manifestations of that. So yeah, but then you'd also have a lot of other stuff going on with the Addison's, the primary adrenal insufficiency as well. But yeah, that's a good one to have on there. Medication side effects, so glucocorticoids can cause like mood disturbances, so keeping that in mind. Brain injuries, neurological problems. Great. Okay, so what we'll want to do then in patients that we have concern for depression is we want to check basic labs, right? Because this can key us into, if there's any vitamin deficiencies, anemia, that good stuff. So doing some electrolytes, vitamin levels, complete blood count, thyroid labs would be a good place to start. Okay. Drug screen. Yeah, exactly. That was not listed, but I think that's super important too. So even though Ryan says, he doesn't take any drugs, you might still want to screen him. Or, if somebody you're more concerned about, you can definitely just do a drug screen. It's not that difficult. So that's a really good one. Thanks for adding that, Chase. Okay. So this slide just here, I think it was from one of my lectures that I had one of my first couple years, but it was really helpful. And it's kind of overwhelming because we're not talking about all of these conditions tonight, but asking all of these things is really important because it can help, even other psychiatric conditions can present as depression, and you want to make sure that you get at the right one because we want to make sure that we're treating our patients with the best treatment available. So for example, like, as we had said, bipolar 1, they kind of alternate between, depression and mania. And so it's important to ask this patient, like, has he ever had times where he feels just like he has so much energy, he doesn't need any sleep, he can conquer the world, he has all of these like ideas and plans that he wants to, do, he's all of that kind of stuff. Any questions that fit this, like questioning about mania. And that's important because you need to differentiate the two, because actually treating someone for major depressive disorder with a medication, as we'll talk about, if you accidentally give that to someone that truly has bipolar disorder, that can trigger mania in these patients. So really important to kind of go through all of these symptoms and everything, which you guys had, mentioned a lot of these that you would ask him. Okay. So assessing suicidality is, really, really, really important. Probably the actually most important thing in patients who are presenting with low mood. So suicide in the adolescent population remains the 3rd leading cause of death. So about 5,000 adolescents die by suicide each year. And the suicide rate is higher among males compared to females. So females do attempt suicide more often, but males complete and die by suicide more often than females. Members of the LGBTQ populations have higher suicide rates, and American Indian and Alaska Native adolescents. So some warning signs are like threats of suicide. Previous suicide attempts is the strongest risk factor if somebody's, attempted suicide before. Having a depression and having mood disorders, showing maybe a preoccupation with death or making arrangements, like a friend is, giving you all of their belongings and stuff, that can be a warning sign. And suicide is preventable, which is why it's really important to have these conversations. So when you interview a patient for suicide, or suicidal ideation, you do obviously want to talk about, have they had any stressors come up recently? You guys have already asked Ryan about that. Do they have recurrent thoughts of past stress, abuse, or trauma? Asking them about substance abuse, asking them about any history of self-injurious behavior. If they have suicidal thoughts, how often are they occurring? How long do they occur? And most importantly, do they have an intent and a plan and access to lethal like implements or drugs? Do they have anything on their person that can harm themselves or others? Yes, absolutely. Yeah, do they have access to anything that could harm themselves, could harm others? Is so important. Yeah, thanks, Chase. Asking about a history of suicide attempt, family history, and do they have protective factors? Do they have good interpersonal relationships with people and support people that they can come to? And so we assess them using a calm, non-judgmental approach, be firm about the need to establish safety, and as we had mentioned, spend at least part of the interview with the teen alone, but also get collateral information from friends, family, therapists, etc. And then the urine drug screen, as Chase had mentioned, is really good. And then some routine labs as well as physical exam. Okay. So here are some risk factors. We've kind of already talked about some of those. One of the most important ones being the previous history. So when is inpatient treatment warranted? So if somebody comes to you with a low mood and you're asking them about their suicidality, when do you need to tell them they need to be admitted to the hospital and put them maybe even in an involuntary hold? That's when they have persistent and or intense thoughts of suicides in specific plans, or if they have previous suicide attempts and they're actively suicidal now, a history of impulsive and dangerous behaviors and active suicidality, inability to come up with specific plans to support their safety, and then lack of adequate support from family and friends. Okay, so thinking about just suicide prevention in general, we had talked about the risk factors, but here on the left-handed side are some protective factors. So things that might be a little common sense, but yeah, having good relationships, being in a safe environment. At the beginning, someone had mentioned asking, do you feel safe in your home? I think that's great. Do they have access to mental health care? Are they part of a religion or a culture that discourages suicide? Sometimes bringing that religion up and talking about that can be helpful. And yeah, do they live in a community where they have lots of connectedness with others? And then this is just like a 5 action steps for helping someone in emotional pain. So you always want to give people resources too, and stay connected, follow up, make sure they have a plan in place to stay safe. Oops. And so here in general, I just wanted to put some like stories about suicide prevention. There are obviously lots of celebrities that are advocates for suicide prevention. Selena Gomez is one that's pretty active with that. There is a guy named Kevin Hines who does a lot of speaking and TED Talks. He's like one of the only 36 people to survive an attempted suicide from the Golden Gate Bridge. There's individuals that have been lost to suicide, such as this girl, Madison Holleran, if you guys had heard about her, but their families often then make a foundation, in the name of their loved one to spread awareness and to raise money for suicide prevention. And then the American Counseling Association has a lot of information about like helplines and resources that are free to people. Okay, So getting back to our case, so the physical exam and lab studies showed no significant abnormalities, so there was no underlying med condition. And he scored a 16 on the PHQ-9 for teens, indicating moderately severe depression. Suicide has crossed his mind before, but he denies current suicidal ideation. He says, "Sometimes I think about dying, but I would never make any plans because it is against my religion." He identifies his parents and his friend John as individuals he can reach out to should he begin to experience suicidal ideation. Ryan's family does not have any firearms in the house. His mother is asked to return to the room for counseling on the diagnosis and shared decision-making regarding pharmacological therapy. So, anybody aware of some treatments for major depressive disorder? SSRIs, right? Yeah, medications, great. Selective serotonin reuptake inhibitors, we'll talk about them. What else? What are some non-medical things maybe? Yeah, psychotherapy, absolutely. Psychotherapy is huge. Great, so cognitive behavioral therapy, dialectical behavior therapy, great. So SSRIs and psychotherapy together often give people like the best prognosis. Okay, so, and then there's also like lifestyle things, right? Counseling on optimizing sleep, nutrition, exercise, socialization. Okay, so what are these SSRIs that are often our first line agents for medical therapy for depression? So it comes from, they were made based on the monoamine hypothesis of mood disorders. So in our bodies, we have monoamine transmitters such as serotonin, norepinephrine, dopamine. They're involved in the regulation of many brain processes such as emotions, arousal, and memory. So the hypothesis, the monoamine hypothesis of depression suggests that disturbances in these neurotransmitters affects mood. And serotonin specifically modulates brain functions associated with depression, such as changes in mood, energy, anxiety, interest, appetite, sleep, etc. So evidence for this was when an early antihypertensive drug called reserpine, which depleted monoamines from the presynaptic terminals of membranes, caused depression in some patients. So that's where this theory came from. So let's talk about that, because if we I'm not sure how many people have taken like a neuroscience course, but remember we have lots of neurons that are sending signals across our brain all the time and generating potentials and excitatory potentials and inhibitory potentials that will, further potentiate the signal. And so really the communication between two nerves comes from this presynaptic neuron and this postsynaptic neuron, and their communication is at the synapse, okay? And so serotonin, this monoamine, when it's released from vesicles from the presynaptic neuron, it can be released in the synapse and it binds to the postsynaptic neuron, and then it'll go on and cause all of its effects, right? And so what they found with this antihypertensive drugs was when they took away a lot of this serotonin from the synapse, when they took it away, that caused depression. So essentially, maybe the opposite would be true, is if we kept more around in the synapse, then maybe people with depression, their symptoms would be alleviated. And so that's exactly what SSRIs did, is they inhibited the reuptake of these serotonin molecules, because once it's in the synapse, eventually it gets reuptaken into the presynaptic neuron again. So basically it just keeps these serotonin molecules out in the synapse longer, so that they have the greater chance of going and binding to these receptors and then, doing all of their things downstream. So really that's what the SSRIs do, is they just increase the amount of serotonin in the synapse, and it's based off of this hypothesis. Okay, so, but this is not the whole story, okay? So it's interesting because SSRIs, you'd think they act immediately, right? So if you give somebody a reuptake inhibitor, it's going to act immediately on that synapse. But in clinical practice, it takes about 2 to 3 weeks for SSRIs to be effective. And people also found that serotonin release and uptake are thought to be actually fairly normal in people with depression. So So research has shown that the behavioral effects of SSRIs are actually probably due to the effects of serotonin on other systems, such as this brain-derived neurotrophic factor. So BDNF. So BDNF, and it's not important to know this receptor, I just wanted to put this image in here, but it signals neurons through receptors such as this tyrosine kinase and activates pathways that lead to cell survival, cell growth, synaptic plasticity, and gene expression. So we're starting to think that maybe keeping serotonin in this synapse longer has effects on this brain-derived neurotrophic factor. Interesting. Okay, so just, a list of some of the SSRIs and their side effects. So common ones are the paroxetine, and the brand names are in parentheses here: fluoxetine, sertraline, citalopram, escitalopram. Fluoxetine and escitalopram are most often used in pediatric patients. Some common side effects when you start the medication or if you stopped it abruptly is like feeling agitated, shaky, anxious, nausea, indigestion, headache, dizziness, etc. This one is important. So in patients who have bipolar disorder, if you don't know they have bipolar disorder because you haven't asked them about any like manic episodes or history of mania, and they're just coming in with like the depression, so then you give them like an SSRI, can actually trigger mania. That's why it's important in all your patients who are coming in with a depressive episode to ask about history of mania. And then in the past, there was a boxed warning on antidepressants because there was thought to be an increased risk of suicidality in young adults that took antidepressants. But newer research indicates that the benefits might actually be greater than the risk, and that the relationship is not causal, right? So that antidepressants aren't necessarily causing that. And so now, more often than not, we do, if an individual needs the antidepressants, especially an adolescent, then we will do shared decision making and prescribe the medication if that's what we want to do. So back to the case. So Ryan and his mother are interested in starting a low-dose antidepressant for Ryan. So Ryan's mother does say that she has a history of depression and fluoxetine works for her. So you decide to start 20 milligrams of fluoxetine daily, and you counsel both Ryan and mother on the side effects. He's also referred to a local therapist, and you plan to see him back in 3 weeks. This is important because you need to know if the medication's working or not. And it takes about that long for it to get, to start to see some of the effects. Somebody had mentioned in the chat, are SSRIs preferred over TCAs, tricyclic antidepressants? Yeah, so tricyclic antidepressants were like one of the first class that was developed, and they are not preferred over SSRIs, and that's because of like the side effects. I am not really sure on the research regarding efficacy. I would probably think that SSRIs are more efficacious in general too, but TCAs, the reason we don't use them is because they have a lot of side effects. And that's like all of your, I'm trying to think, let's see, autonomic nervous system. There we go. I couldn't think of the word, but like it messes with that. And you can have a lot of side effects because of that, especially in like elderly patients. It's really important not to give them, TCAs, or at least like really think about having another medication. It could be a last resort, but usually, yeah, SSRIs are a lot cleaner drug, but great question. So yeah, so Ryan returns in 3 weeks. He's doing better. He did have some mild nausea the first week, but it's resolved now, and he does not feel back to his normal self, but he thinks he has more energy. He's engaging more in conversation. His mother says she notices him laughing and smiling more, and he has begun to eat dinner with the family again. He had his first 2 appointments with his new therapist. He sees her once per week. He's denied suicidal ideation, and you'll see him back in a month. So it's really important to keep like following up with these patients when they're first starting their medication, because you want to make sure it's working. And also too, you want to check in on them, right? And you want to ask them every time, perform, a suicide risk assessment is really important too. Okay, so we're getting right at that time. So these are my sources. And so if you guys want to do the quiz, you're free to do that. And we will see you not next Wednesday, but in 2 Wednesdays. One of my colleagues will be giving the next talk. I forgot what she's giving it on, but yeah, thanks everybody for coming and for participating. Hopefully this was helped you, was insightful, and maybe you learned something new. So, all right, thanks everyone. See you next time.